My name is Dr. Mansoor Ahmad. I'm presently working as Chief of Heart Center at Medicare Cardiac and General Hospital and Suhail University in Karachi. Now, to start with, we'll talk about bifurcation lesions, its classification, and what is important in assessment. European Bifurcation Club defines bifurcation lesion as a significant stenosis that is of more than 50% involving the division of a significant coronary artery at or near the bifurcation. These lesions are called complex because the technique involved can be complex, and at the end of the day, the outcome may remain suboptimal in a substantial number of cases. It requires a certain expertise which one learns over a period of time, and with experience gain expertise. Now, the requirement to start a procedure, number one is a good coronary angiogram which shows very clearly the extent of the disease, the bifurcation angle, is there any calcifications, is there a thrombus or any other significant abnormality. Another important factor that affects the management is the morphology of the plaque. Is it calcified? If so, how much and where exactly calcification is located? In fact, to define the morphology, imaging is also very helpful using an IVUS or OCT, which may not be always available with us, and sometimes it overshoots the cost for a particular patient, as we do not have an insurance cover for all the patients. To understand the lesion itself is important so that one can plan the strategy that has to be adopted to treat this particular lesions and decide what tools will be needed, starting with the guide catheter, that the wires, do we need a cutting balloon, do we need a rota, and certain other technologies. Lesion preparation is very important, and of course, when we are treating, then we have to decide either we are going to approach it with provisional stent technique or front two stents. Before that, an important point is the classification of bifurcation lesions, and the well-known classification and acceptable classification, which is extremely simple to understand, is Medina classification. So briefly, let's talk about Medina classification, which is very useful for practical purposes for our procedures. And this involves bifurcation, means a main branch and a side branch. So here it shows this is a main branch and this is a side branch that's coming out of it. Now, how do we classify it? Main branch lesion, anything that has a lesion of more than 50% stenosis is given a number 1. So if the lesion is in the proximal part of main branch, it's 1 there, and main branch distal, that is distal to the branch, is a distal lesion. If there is a lesion, again 1, and in the side branch, that is 1 again. So here it says this is lesion in proximal, lesion in distal, lesion in side branch. So it is 1, 1, 1 as it's classified there. Now here we see lesion in proximal main branch and distal main branch, but no lesion in the side branch. So it is 1, 1, 0. So side branch is third. First is proximal main vessel, second is distal main vessel, and third is side branch. And the third one, again, all kinds are visible here. This is proximal 1 with no lesion in distal, so 0, and side branch lesion is 1, so 1, 0, 1. Similarly, there is no lesion in proximal, so 0 plus 1 and 1. Here it's just proximal and nowhere else, so it's 1, 0, 0. It's only distal main branch, so it's 0, 1, 0. and it's only side branch involved. So it's 0, 0 and 1. So this is Medina classification. This helps us in planning our procedural strategy and decision as to whether this should be a provisional stenting or upfront 2 stent techniques that we have to use. On the basis of this, most of the decision can be made.